therapists. So can you kind of explain to me the rationale behind that? Thank you.
Originally, the rationale behind the extended care permits were to have that somewhat of a tiptoe bridge to create that access to oral health care in some alternative settings. And what it is there's 3 levels. The first level, ECP1, only, you're required to have so many hours of clinical experience, and they are only allowed to do just oral health education, I think, for the infants. ECP2 has several more hundred hours that they have to certify through the state of Kansas, and they would receive the ECP2, and they would be allowed under the general collaboration of a dentist or a supervising dentist to go out to the possibly the schools to provide oral health education, oral health care right there in the schools, fluoride varnish treatments, and some sealants. Now, the ECP3 is the next level, and we are only limited, and as an EC3P myself, we are only limited to do so much for those residents. We do have a 6-month training modules that is given by the UMKC School of Dental Hygiene, and we have 6 months of training in those modules for didactics, and then we have a weekend of providing hands-on practical skills while we are able to provide just that next step more. And some of these practical skills, actually, I have lists of removing and straining its deposits, very similar to what a dental hygienist do, but also it includes doing a soft reline repair for an older adult in a nursing home who needs their dentures fixed, some adjustments for dentures, and the other one is smoothing of a sharp tooth with a slow speed on a handpiece. I'm going through the list directly from the Dental Practice Act that states this. Extraction of deciduous teeth that are partially exfoliated with a class 4 mobility, and other duties can be delegated verbally or in writing by that sponsoring dentist. But the thing is that when we go out to those nursing homes as ECP3s or to those rural areas, I've been finding there is much more comprehensive need for these patients to get treatment, like providing, hey, can I be able to prescribe an antibiotic so we can get a dentist here to come take care of it? We have to jump through a lot of hoops. But we are very limited to what our abilities are as an ECP3, and the Kansas Dental Therapist Bill is actually that next step to take that step forward, so we are able to provide even more care for those residents and those populations that are truly underserved in the state. I hope that clears that up.
Mr. Chair, just quickly, do you know about how many dental hygienists have gone on to get those different levels?
My guess at this point, the exact numbers, because they've got a class going, I think, right now at UMKC, and I think the number currently is 140 or 150 ECP3s. There are many other ECPs that I do not have that number, but I can get back to you with the exact accurate amount later.
Mr. Chair.
Senator O'Shea.
Thank you, Mr. Chair. I'm curious, the hygienist and the therapist and the dentist, are they all under the Board of Healing Arts?
No, they're under the Board of Dentistry.
All 3 of them?
Mm-hmm.
Okay. Follow-up question. It seems somewhat similar to the APRN bill I think we're going to be hearing tomorrow in terms of needing that supervisor that is or isn't super involved in what the therapist is doing. And so I'm just wondering what's the correlation, and what kind of price might these supervisors be asking of these therapists? And I'm just curious how that relationship's going to work and what that really does to enhance it. Thank you.
Are you inquiring the salary intake or what? I need a little more clarification.
Senator O'Shea, are you talking about collaborative agreement? I do not believe this is a collaborative agreement process. This is just a strictly statute process. Senator Stephan and Senator Gossage.
Chairman, I had come across my desk, they used Minnesota as an example, that and I don't know how long they've had dental therapists, but there was like now like 100 of them, and like 8 of them had ended up in rural and underserved areas. And I know we've talked about that aspect of it to a great deal. Would you be interested in codifying within a law that the therapists would be limited to being employed at federally qualified health centers or working in underserved counties without dentists only?
That is, I'm sorry, sir. That is actually kind of the key of why we need these dental therapists. Absolutely. Federally qualified health care centers can be a starting point of where we can bridge that access to care issues in those rural communities.
Is that a yes?
Yes, I'm sorry, sir.
Senator Gossage.
Thank you, Mr. Chair. Thank you, Julie. Follow-up question to that. When it says that the supervising dentist must accept Medicaid, but as our other senator has just said here, that doesn't necessarily mean they're in an underserved area. Could have a dentist in a very affluent area that accepts Medicaid, but may have only 2 Medicaid patients, so he could have a dental therapist, correct?
That would be my understanding. Travis, I think you could probably clarify with that a little bit better than I can at this moment.
Thank you.
Senator Holscher.
Thank you, Mr. Chair. I just have a question as far as pricing of procedures. Is the pricing level the same for a patient if it's a dentist versus a dental therapist? Or is there a difference as far as what the patient would then be paying, depending on who's performing it?
That's a really good question. And at this stage of the game, that's almost way too over my head when it comes to pricing and dental CDT codes. I'm going to pass that on to Travis if he's got a little bit more insight on it. Just getting this legislation is going to be the first step.
Mr. Chairman, briefly, I'd probably yield and allow the Dental Association an opportunity to answer that if they choose, if that's right.
Thank you, Travis, and thank you, conferees. Senator Thompson will be our last question, and we'll move on to opponents.
Thank you, Mr. Chair. With regard to insurance, I'm assuming that they would be required to carry the same type of liability insurance as a dentist, considering they're performing some of the same procedures, correct?
Yes, sir. Actually, dental hygienists currently carry liability insurance to practice now. And some have independent liability insurances. Some practices actually offer that to their dental hygienists. As for dental therapists, it would probably be very comparable to what the other states who already have dental therapists in place. That's where that liability coverage would probably mirror.
I could follow one very quick question. So is, having that and having all these additional licensing fees, is that a barrier to entry for people into the dental therapy group? In other words, moving up from a hygienist to a dental therapist?
It is an investment in this step for bridging that access to care and being able to provide the care that we would like to provide for our community. It is an investment. It's very similar to investing in our licensures that we have to maintain. It's also an investment to be able to maintain our continuing education credits that we are all required as licensed professionals to maintain as well. Of course, it'll be an investment, but this is something that needs to happen, and it's time.
Thank you, Mr. Chair. Thank you.
Committee members, we do not have any neutral testimony today, so we will now move on to opponents. First up, we have Kevin Robertson. He's the Executive Director for the Kansas Dental Association. Kevin, welcome to the committee.
Thank you, Mr. Chairman. I am Kevin Robertson, Executive Director of the Kansas Dental Association. It's certainly an honor to be here before you today to discuss the Kansas Dental Association's position on Senate Bill 129. And let me assure the committee that the KDA is strongly opposed to Senate Bill 129. Dental therapists have not improved access to dental care anywhere it has been enacted, and it has not saved taxpayer dollars. And the number of dentists in the state of Kansas is increasing dramatically, and we believe those are the ways that we will increase access to care throughout our entire state. There are many challenges that Kansans face with regard to seeking a dentist, whether that is the cost of that dental care and whether or not they have insurance. We've talked about that before with the a couple weeks ago. Fear, or maybe even the belief that they don't need care. The Kansas Mission of Mercy, which is our free dental clinic that we hold annually, we've treated over 30,000 people, and we do exit survey those individuals. And what we have found over the years is that less than 3% of KMOM patients say that they went to the clinic because they couldn't find a dentist in their general area. 87% say they have issues with paying, if they didn't have insurance or they couldn't afford the care, didn't believe they could afford the care, and 8% said they just didn't think they needed the care in the first place. The creation of a dental therapist does not address these barriers. To this point, Minnesota approved dental therapy back in 2009. That's the longest standing dental therapy program in the 48 states. That's kind of what we're talking about here today. And as mentioned earlier, only 8 of 99 dental therapists were practicing in census-designated rural areas in 2020. The state has seen no reduction in the number of emergency room visits. And back in 2017, the federal government issued a warning to Minnesota that not enough children on Medicaid were receiving dental care. Patients treated by dental therapists save no money, whether or not you receive a filling from a dentist or a dental therapist. That is in the code of dental terminology. That's this book, actually, this 21 book. So that code is the same for a tooth filling, and the reimbursement rate's going to be the same, whether that's out of pocket or through a third-party payer, Medicaid, or an insurance company. The few states that have adopted therapy programs actually cost taxpayers more money. In Vermont, they received a federal grant of $400,000. They've applied for $1.6 million. So that's costing all of us money for their program. And again, the number of dentists in the state of Kansas over the last 10 years exceeds the population growth in the state by 4 times. 14% in growth in the number of dentists versus only 3.4% in the number of population. And let me say that I did get a hold of SkyGen USA. That's the CanCare dental subcontractor. They've told me that in the last 3 years, the number of dentists that are in their network has gone up from 411 to 496 dentists. So we're seeing increases in the number of dentists throughout the state in all areas, and we believe that that is the way to move forward with increasing access in our state.
Kevin, thank you for your testimony. And committee members, again, we will hold questions until all opponents have had an opportunity to present. Next up, we have Dr. Alan Rivas. He is the KDA president, and he is from Atchison, Kansas. Welcome to the committee, Alan. Dr. Allen.
Thank you, Senator Hildebrand. To you and all the committee members, I welcome the opportunity to testify on this bill. I practice general dentistry in Atchison, Kansas. I represent Kansas dentists and myself in strongly opposing this bill. I've been practicing for 37 years. I've been a Medicaid provider for adults and children the entire time. I helped start a safety net clinic, which is now an FQHC. I've done volunteer service there, and I'm on the board there. So we took it on locally to meet the needs that we need to take care of the people with Medicaid and low income. I also served on the Kansas Dental Board at a time we established a scaling assistant initiative. At the same time, we passed general supervision for the hygienist. Since then, we've expanded the ECP program several times. And so in the last, say, 20 years, we've done several things to improve access to care and empower hygienists to be able to provide more care. The dental therapy issues persisted for over a decade and it becomes more relevant each year. The dental deserts are no longer an issue as we are improving access to care to all these areas. 3 factors contribute to that change. We've increased the dentists in Kansas at a rate higher than our population growth. The KIND program, which is the Kansas Initiative for New Dentists, has added several dentists in underserved areas in our state. That's where they get a scholarship in dental school, and then they can go to one of these communities in need and do a commitment for so many years. The growth of FQHCs and safety net clinics, no one's talking about. There's been a big increase in safety net clinics and FQHCs in rural and underserved areas over the last 20 years. It appears the trend is positive to bring dental care to our citizens with the professionally trained caregivers we have in place. Senators, we're going through a really incredibly challenging time with the pandemic. Dentistry's been hit. There have been challenges for us to ensure patients and the dental team is safe while providing care. Most practices are not back to full operation. Many patients are delaying care, and dental offices have lost employees due to COVID-19 fears. These are real concerns, and all dentists are focused on how to safely practice their profession. The concept of a dental therapist is not a good idea to start with, but to introduce this shift in treatment during all the other challenges is a poor idea. It's not fair to the patients, it's not fair to our team, and it wouldn't be fair to the dental therapists. The overwhelming concerns dentists expressed to me is patient safety and the training of the dental therapist. As you know, from your own personal experience about dentistry, all you know is what you had to deal with. If you had pretty good checkups, if you had pretty good health, you wouldn't have as big an understanding of some of the complexities we deal with. Today's patients are more complex than ever. We deal with behavioral and mental issues often, medical conditions, medications, and the interactions they have with the medications we use are increasingly complicated. Today's dental practices have far more complicated equipment, materials, and technology than ever before. So we need to understand the training of the providers. The dental hygienist is trained in preventative care and to help with patient histories and help assess the patient. The dental therapist, to take the implement dental therapy role, they're going to be operating equipment that they're not trained with. There's many potential mistakes that can happen. They don't deal with high-speed hand pieces. They don't use lasers. There's a lot of technology that they do not use. So it's a big jump, and it's something we need to be very cautious about. One of the talking points I've heard about this issue is the dental therapist and APRN, or advanced practice registered nurse, are virtually the same approach to mid-level provider. One's in medicine, one's in dentistry. This view shows they need to learn more about these roles. When a nurse becomes an APRN, they'll still be in a nursing role with more responsibilities as a nurse. Basically, she's going to stay in her alley, maybe more specialized in nursing. For the nurse, they already have this training and knowledge. For the dental therapist,
Rivas, I apologize, but we're running a little bit low on time, and your 3 minutes was up probably 3 minutes ago. So if it's okay, we are going to move on to Dr. Jenkins. Dr. Rivas, thank you for your testimony.
Sure.
And Dr. Jenkins, if you could, please keep it under 3 minutes. And welcome
I'll
to the committee.
Thank you so much. I'm Jill Jenkins. I am a board-certified pediatric dentist and president-elect of the Kansas Dental Association. It's my professional opinion, after 15 years as a practicing pediatric dentist, that establishing a mid-level service provider or dental therapist would create a tiered system of healthcare in the state, inevitably leading to substandard care, especially for the most vulnerable of the population, our children. Dental care for children is so much more than taking x-rays, cleaning teeth, and giving them a goodie bag for a job well done. Treating children with the procedures recommended in Senate Bill 129 requires 4 years of training in dental school, and for me, an additional 2 years of pediatric specialty training to attain the knowledge, experience, and skills needed to competently and safely treat these patients. A parent relies on their state board and legislators to determine what is an optimally safe environment for them to seek dental care for their children. The relationships I have established with children and their families over the years requires a team effort to build, but ultimately, parents put their trust in me, the dentist, to safely treat their child's dental needs. If given the opportunity for your child, would you choose a dentist with countless experiences through 4 years of dental school and beyond, or would you feel good about walking into a dental clinic that utilizes a dental therapist to treat your child instead? What if, like a lot of the population, you didn't know the difference or simply couldn't afford to take your child anywhere besides a county clinic that only employs a dental therapist instead of a trained dentist? And what if the therapist was placing a space maintainer? It's in their recommended unsupervised procedures, along with numbing shots and nitrous oxide sedation. And that child became combative and scared. It's what they do. And the child started flailing their arms and trying to move away from the therapist and began choking on the metal space maintainer. Or the dental therapist is attempting to do a filling in this chaotic environment with an uncooperative child with drills running up to 400,000 RPMs. When a child is injured in this environment, who will be responsible? I had the privilege of starting out my dental career practicing in Gove and Trigo counties for over 3 years. After a few months, it was obvious that treating children was my true calling in dentistry. It was not uncommon for parents to drive west from Hutchinson and east from Goodland for their children's dental care. I questioned a lot of them over the years about how inconvenient it must be for them to travel to see me so many miles. The responses varied from, we plan our visits around the sale barn on Wednesdays anyway, to we drive straight up here from Hayes to do our monthly trip to Walmart, and it saves us a trip to Kansas City, so thanks for being here. After I completed my 2-year pediatric residency, I even had families come up to Kansas City for years for their children's dental care. It is up to us to make decisions to protect the public. Dental therapists are not the answer to providing care to the underserved children of our state. All parents deserve to trust that a true dentist is caring for their child, regardless of their socioeconomic status or type of insurance they hold. Instead of developing a new costly system to train underqualified dental professionals, why don't we develop systems to encourage dentists already licensed to provide access to these dental deserts and safely care for the most precious resource our state has for the future, its children? Thank you.
Dr. Jenkins, thank you for your testimony. Dr. Matt Standridge, welcome to the committee, and if you could keep your testimony for under 3 minutes, that would be great. Thank you.
Thank you very much for having me. I am both honored to represent myself and my colleagues and patients as well. I did offer written testimony where I dive in deeper into these subjects. I will overview to keep within those 3 minutes. The topic of access to care is very important to me. I have daily experience with the issue because I practice in a quote underserved area. I've also started my profession in working in FQHCs, and then my first clinic my first practice that I started privately, I was a recipient of the KIND grant that was mentioned earlier, and I accepted Medicaid in my private office. So I've had a unique spectrum of experience in all of these different areas. Allow me to switch gears and talk about definitions a bit. Most services that we treat with dental disease, especially around the issue of cavities, are both surgical and irreversible. That means you are cutting away or removing a body part, and that body part isn't coming back. It takes years of training to do this and do it well. That's the difference between our general medicine counterparts. Doctors have nurse practitioners and physician's assistants, but they're not a surgical driven model like a lot of dentistry is. There's a reason no non-doctor surgeons exist in the medical world. It would be a level of substandard care, and why would we want that same substandard care for the citizens of Kansas? Next, if we look at states, as mentioned earlier, that have already implemented therapists, they have not made any appreciable measures of improvement whatsoever. These people don't come to dental deserts like where I practice in. They go to urban and populated areas, and they also have not shown to curb rates of disease. My biggest soapbox is the vast majority of dental issues are indeed 100% preventable. And it comes through, and the only way that we're going to curb that is through education and prevention outreach. Take a standard child age breakfast consisting of cereal, milk, and orange juice. That all breaks down to sugar in the mouth. That is a perfect cavity causing meal. And I find it interesting that the Kellogg Foundation, a wide supporter of the therapist model, is the same Kellogg's that sells sugary cavity causing cereals geared toward children. In the end, we cannot drill ourselves out of this, just like we can't attack the obesity crisis by creating liposuction therapists. Our times and resources would be much better suited to gear towards prevention and getting trained professionals to these areas. Thank you.
Thank you, Dr. Standridge. If I can how to push my button on my mic, I would be a little bit more vocal out here. Dr. Cope or Lynn Scott, welcome to the committee. And if you could keep your testimony for under 3 minutes, that'd be appreciated. Thank you. Dr. Lynn Scott, are you available?
Yes, can you hear me?
Yes, we can now. Those buttons
Okay,
are hard to push sometimes. So.
I know, sorry. Thank you, Chairman. I'm a dentist and licensed in Kansas and Missouri. I have been practicing for just over 5 years. I've had experience practicing in the corporate-run dental office, a federally qualified health center, and private practice. So I won't go into the fact that dentists are already oversaturated, and that the problem with the bill is that it does limit dental therapists to FQHCs in underserved areas, because that's already been talked about. I think that there are better ways to incentivize the dentists to practice in underserved areas, and the focus should be redirected from this bill about dental therapists and extended care permits to improving oral health education efforts to reduce the patient's need for fillings and dental care in the first place, similar to what the previous testimony stated. In my practice of dentistry, I'm frustrated by the lack of health and dietary and oral knowledge by the general public. If we would focus efforts on improving oral health and education, I think Kansans would have improved oral health and overall less dental disease and need for fillings and extractions, and overall improved health. I think from kindergarten on, students in public schools should be exposed to curriculum about oral health and hygiene. Rather than passing this bill, the government should focus on working with dentists, doctors, and educators to develop this curriculum. For example, we should tell kindergartners about sugar bugs and how they should brush their teeth, floss, and avoid eating or drinking sugary things like soda pop, candy, and chips so the sugar bugs don't make their teeth go bad. And explain to fifth graders a more complicated explanation and tell them how much sugar is in soda and how it can affect your blood sugar and also lead to cavities. And possibly give kids disclosing tablets to show them where they need to brush better and explain and practice flossing techniques. Could teachers present this curriculum? Could oral health advocates be paid to present this information? Could substitute teachers be trained to present this health information when they sub? Those are a few ideas. In my practice at the federally qualified health center, I was also frustrated at how many patients did not show up to their appointments. Can you hear me?
Yeah,
Sorry,
doctor.
I
apologize, but our time is really short and we're over our 3 minutes. So we need to move on to the last conference. Okay. But we do appreciate you, your testimony. And next up, committee members, we have Alexandria Blasi. She's the Executive Secretary for the Kansas Board of Pharmacy. Alexandra, welcome to the committee.
Thank you, Mr. Chair. I will do my best to be brief. You have my testimony. The Board of Pharmacy does not generally pop up on dentistry bills. However, Senate Bill 129 presents some concerns to the board, specifically in one very clear subsection, and that occurs on page 3, line 37 in subsection D17. And essentially what you have in that section is an allowance for dental therapists to dispense and administer by the topical or oral route any non-narcotic analgesics, anti-inflammatories, and antibiotic medications as prescribed by a licensed healthcare provider. This is concerning because it is very broad language that is not limited to prescriptions from licensed dentists. The definition of a licensed healthcare provider includes any prescriber in the state of Kansas, and would allow dental therapists to fill any prescription, regardless of whether it was related to the dental care. Now, the Board of Pharmacy has brought this issue since this bill has been introduced in several previous sessions to the attention of the conferees many times, and unfortunately, it has not been changed. The board is perplexed by this because if the intent really is to be specific to dental therapy, then this section could easily be modified to limit to the appropriate dispensing of medications to the patient. Unfortunately, it continues to remain very broad. I'd like to be clear that when dispensing medications, it is very important that the individual conduct a full patient profile review drug interactions and allergies, properly label medications, and counsel patients. And this is something that the pharmacists do, as well as physicians that dispense directly to patients. Also, just because it's been brought up, neither APRNs nor PAs may dispense medications to patients. So this would be a very unique carve out, and the board is unclear why that's happened. And with that, Mr. Chair, I will stop, and I'll be happy to stand for questions at the appropriate time.
Sandra, I appreciate your testimony. Committee members, we are running really short on time, so if you could just keep your questions very short, and conferees, if you could keep your answers very short. I do not want to cut anybody off on questions. I know these are very important. So if we do run out of time, conferees, would you be available to answer any questions via email if we send them to you from the committee members? Okay, thank you.
Of course.
Senator O'Shea.
Thank you, Mr. Chair. This is for Mr. Robertson. I'm curious, it's from Mr. Lowe's testimony, this was supported by the KDA a number of years ago, and so I was curious why the dentists have changed their position. Thank you.
Yeah, thank you. That's a good question. I appreciate that. In 2018, the Kansas Dental Association did support Senate Bill 312. I would say that the leadership of the organization at that time felt like the membership was at a point to do that. I will tell you that there was a significant level of disapproval from our members when we did that, and we have changed our position immediately following that particular legislative session. So we have been opposed really from about April 2018 back till today.
Senator Stephan.
Chairman, Kevin, you probably better stay up there. Kind of a couple or three real quick questions. One of them I'll answer myself. Yeah, the dentist is at the top of the chain. They're the gold standard for oral care. Agreed? Yeah. And in comparison to the Minnesota results, that's over a decade, they put like eight dentists or eight dental therapists out into underserved areas. Under 100 in total. Does the dental academia understand that there's still a need for dentists? Are they trying to expand the number of dentists coming out? And can you match here in Kansas what came out of the dental therapists' efforts in Minnesota?
Yeah, no, I appreciate that question. I can tell you that over the last 10 years, the number of dentists in the state, or in the country, really, if you go back 20 years, dentistry was putting out about 3,800 dentists a year. In 2020, 6,300 dentists graduated from the schools of dentistry. Just in our area alone, Missouri school in Kirkland, Missouri, started up in 2017, graduated their first class. Joplin, Missouri is looking at a private school. Actually, I think they start classes a year from now. I don't know if COVID has affected that. So just in our immediate neighborhood, there's been some new schools, and I can tell you that UMKC, Creighton, University of Nebraska have all increased the size of their dental schools over the last several years as well. So that is why Kansas has increased the number of total dentists so dramatically in the last several years. So yes, it is happening, and estimates are through at least 2035, the number of dentists in the state of in the country will continue to increase.
Okay. Committee members, we have time for one last quick question and quick answer. Committee members, I apologize if you did not get to ask your question. Would you please email Donola with your question, and we will get that answer back to you. Senator Gossage.
Very quick question, and that is, why would one, as a dental hygienist, go on to become a dental therapist when they could pursue a training as a dentist?
You know, I think the answer to that question really would fall better to Mr. Lowe. I imagine it's an income issue for them. It's sort of would be an in-between income, but I don't know exactly what the income model is. Hygienists typically are paid, going to depend on the area of the state, but they're a fairly well-paid profession.
Committee members, we are out of time and overtime, so we are adjourned. Thank you.